You can see them.
Good morning, ladies and gentlemen. I might ask you just to make sure you've got your cup of tea and your refreshments before we start the morning's procedures. It's so nice to see us all back in one spot, isn't it? 2 years since we had a combined clubs morning tea, and we've got a really good crowd in today and really excellent representation from a number of different clubs, so it's great to see. It's really good to see so many of you here today. So before we start, I've got just a little bit of housekeeping to do. For those who don't know where the toilets are, if you've never been to Mingara before, and it is a little bit of a difficulty finding your way around, I have heard people say that. The toilets basically are out there on my right. So you go out the door and you head to the right, and all three toilets are there together. So the disability accessible toilets, the female and the male as well. Okay, so just to remind you that we are live streaming as we go today. This is our test case. The lovely Rachel and Lani and Maria are much better at this sort of stuff than I am. So aren't we privileged to have three lovely young women who can do all of this stuff in-house for us? It's a really excellent skill to have. And this is the first time we've used the camera, so here's hoping it all works. Before we start, I want to plug the book. The book is a new book which is called Finding Yourself After a Stroke, and two of our authors are with us today, the lovely Brenda Booth and the beautiful Emma Beasley. Okay. So Brenda has copies here for sale if you'd like to purchase one today, and they're $30 a copy. And the profits for her sales go to the Stroke Recovery Association, which is really lovely of Brenda as usual. So we're going to basically have a lovely young woman speak to us today about the role of nursing after stroke. It's one of the really key roles of any hospital. And one of the things about nursing is that you everywhere along your journey with your stroke, there's always a nurse involved. They're the first point of call for anything. Do I need to go to the toilet? Do I need food? Who do I talk to? And the nurse has a really key role. But the other thing is the role of the nurse is becoming much more, I guess, complex. And they have all sorts of roles. And one of Kylie's great skills is that she's at the real forefront of that change. So it's a real privilege to have Kylie with us today. So I'm going to introduce her off the top of my head, and I do hope I do you justice, can I say. So, Kylie Tastula, and she's a nurse practitioner, one of the very few nurse practitioners in New South Wales. She's the Neuroscience CNC as well at Royal Prince Alfred Hospital, and she's one of the key figures in the endovascular clot retrieval process that occurs when people come down from the country to RPAs. She's also the nursing co-chair of the Agency for Clinical Innovation, and that is the organisation within New South Wales Health that really drives change. And over the last 20 years has been the organisation within New South Wales Health that has really driven excellent quality of care and made sure that stroke treatment in New South Wales is not only up to speed, but is world class. And so Kylie is one of the key figures in that as well. And apart from that, she's also just recently taken up a position on our board. And it's a real privilege to have somebody who's a key mover and shaker within New South Wales Health on our board. So it's my sincere pleasure to introduce you to Kylie Tastula this morning, who's going to cover the role of nursing in stroke.
Right, I think Michelle stole half my thunder and said that nurses are a big part of every part of your stroke journey, but I'm sort of trying to go through the beginning to the end and the different types of nurses that you might come across within your hospital stay. So I will say I work in the very hyperacute part, so I tend to see you for the first few hours and then I see you again at clinics, but there is very different parts of the journey throughout. But I think as Michelle said, I think as a nurse, one of my biggest roles, I think, is advocacy, and that's on behalf of both nursing and of our patients and families thereabouts. I think talking to a few people this morning in terms of COVID has made it very difficult, especially when you can't come into hospitals to visit, and I think that's a big part of what we've had to try and play, to be that voice for you guys when you're actually not allowed to be into the hospitals, and we'll see what happens in the future in terms of visiting as well, but I think that's our largest role at the moment. So there's a lot of different areas that we play. There's sort of that direct patient care that everyone traditionally has always known about what nurses do. There's care coordination. We're involved in coordinating all of the care of stroke patients. The inpatient care, there's outpatient areas, and there's a lot of education, there's a lot of research that goes into things, and nurses play pivotal roles in all of those areas. In terms of the direct patient care, that's the part that you guys would probably know most frequently, and that's the part that everyone thinks about when they think of nursing, and they sort of provide that constant care that you require. They are the people, I won't be doctor bashing anyone, but they are the ones that sort of alert any medical teams that there is something wrong. They're the ones that are with you 24/7. They're the ones that see changes. They're the ones who can communicate on everyone else's behalf when people don't tend to listen to people when they're concerned. They do cover all of your needs, whether it's feeding, stopping you from falling out of bed, getting you up walking, doing all those sorts of things. And they provide a link. Often, the one thing I do tend to find is when people do their rounds of a morning, everyone sits in a bed and they completely forget every question they've ever had. And they're sort of intimidated by the 12 people who have decided they're going to round. It's often the nurse at that bedside who can be that voice for you and remind you to ask your questions and remind you what to actually do. And then sort of translate all of that into English once everyone has left. Also there to provide some education around what's happening, what's going to happen, and then provide comfort, I guess, is probably one of the biggest things that has occurred of late. I think that's especially hard during COVID at the moment, when families can't come in to do that. So in terms of care coordination, so there's either stroke nurses that do that, or there's allied health teams. So depending on what hospital you work at, the stroke coordinator role will be nursing or allied health, but they tend to basically coordinate your entire hospital stay. They're the ones who make sure you have your entire stroke workup. They're the ones who make sure you're going home on the right medications, and they're the ones that make sure you know what all of that means. So the person who's central to that is the one that does all of that. So whilst they might not necessarily be the ones who are ordering all of those and making sure that happens, they are the ones that actually are ticking boxes to ensure that you have gone home on the appropriate things. They also talk to the entire team. So in terms of when I talk about my stroke team, I include ambulance, I include the emergency department, I include radiology, ICU, anaesthetics, the stroke ward, and allied health teams. So it's actually a huge team, and I guess for me in my role, I'm the one person who's in the middle of all of that, and I coordinate all of those departments to work together. And that's a lot of what our coordination is, to make sure everyone's sort of working together, doing the same thing, rather than everyone having 15 different plans for one person and none of them actually work. So we're there to coordinate that one goal for everyone. And I guess that one goal is to facilitate your discharge planning, to get you out of hospital as, we like to say, as quick as we can. People might think that that's a bit too quick in some circumstances, but that's our goal, to try and get you out of hospital as safely and to the appropriate location. So the role of the stroke CNC probably varies greatly from hospital to hospital, and it's set up very differently depending on where you work. So at RPA, that's actually not my job, I'm not the stroke CNC. That's all right. No, I'm neurosciences, so we actually have a specific stroke CNC, and the job for that person is they coordinate all of your care once you get to the stroke unit. I tend to be the face you see when you come into emergency. They're the ones that then on the stroke unit, they provide all of the education on the stroke unit. So that education might be to you, to teach you all about your stroke, the risk factors, the lifestyle changes and things that you might need to make or that you can change to try and decrease your risk of having a stroke. They also provide that link, as I said. So our stroke CNC is the one that anything new that comes in, so new policies or new protocols, they're the ones who implement all of that amongst the team. They're the ones who make sure that the consultant is paying attention to what the physio says, who's paying attention to what the occupational therapist says. She's the one that makes sure everyone has that voice. Because often you'll find our doctors might come through and they'll say, yep, this person's ready to go home, whereas the physios have thought, no, you're not ready to go home, you're potentially likely to fall. So they're that one person who stands on that round and says, no, they can't go home, so-and-so has felt this about you. So they sort of coordinate all of that to make sure what happens should be happening. Education. I think education is a huge part of all of our roles. Education to consumers, so to everyone out there, so we know what's going on, so you guys know what you're entitled to, what you should be getting, what you should be receiving. Also to nursing staff, to make sure that they're aware as to what's happening. So there's always, stroke has changed extraordinarily over the last 10, 15 years. And so we need to provide education to make sure everyone's aware of that and to make sure what's changes need to be made. Families and carers, I think, as I said, often the rounds, we do rounds and we think we've told everyone exactly what's going on and it's nice and clear. Doesn't mean that that's actually what you've heard and what your understanding of things as well. So a lot of it, when I orientate people into that role, I tell them they need to go back around and re-explain the exact same things again, because often we need to tell things multiple times to multiple different people to make sure the messages are getting through and to make sure all the questions you guys have are actually being answered. And then all of our other healthcare providers. We all provide different parts of the care that you need, and we need to all make sure that we're actually working together to provide the exact same thing and that everyone is doing the best, most up-to-date clinical guidelines. There's also lots of research that occurs, so CNCs are often part of implementing that research or helping find patients to participate in that research. Making sure that we actually provide the care as according to the guidelines. They change on a regular basis. We've now got living guidelines that are actually updated all the time. So as new evidence comes in, that gets changed. It used to take about 10 years for anything to happen. Now we sort of have to do it as soon as it goes through. So a large part of that is implementing those and then ensuring that you're actually meeting those standards. So just because I say we're doing a good job doesn't mean we are doing a good job. We need to actually be able to prove that we are meeting those standards and we're doing what we're meant to do. So when you first get into hospital, you hit the emergency department. And I'm not sure how many of you realise that the only way you get through an emergency department to see a doctor is via a triage nurse. So the triage nurse is your first port of call. They're the first person you speak to, and they're the ones that decide how quickly you get assessed. So there's 5 different categories that they use. Stroke, generally speaking, is a category 2, which means you've got 10 minutes to be assessed by a medical staff member. If you're having a heart attack, it's the same thing. If you're coming in requiring CPR, that's the only one that generally is a category 1. Otherwise, everything else is determined by that triage nurse initially to decide how quickly you're going to be seen and whether you're seen in a bed, whether you're seen in the waiting room, which is probably more frequently now, or if you're really unlucky in a tent outside of a hospital. So they also provide all of the care in the resus. Well, for stroke for us tends to all go to the resus unit. So they provide all of that initial care there. So they work with stroke teams and they sort of do all of that initial, taking your assessment, getting a quick story, making sure your odds and everything are normal. And then they're trying to do some education and they're also trying to get all the necessary equipment that you need. And I'll sort of go through what that looks like as we run through a short call. And then that's sort of where my role sort of comes into it when we start talking about the stroke team. So if that triage nurse has determined that you're fast positive, is what we call it for someone who's having a stroke, they will then activate the stroke team, which calls us down there. And obviously we like to be there as quick as we possibly can. And our stroke call at RPA notifies a whole bunch of us and it makes sure I know that we're down there, make sure emergency knows so more people in the ED are aware. And it also gets our radiology department waiting, so they empty the CT scanner for us so we're not waiting for things. And a lot of it is trying to improve those processes and make sure everything runs smoothly. And at this point, I will will say, I thought I was reasonably good at communicating and talking to families, but we did have a mock stroke call a few years ago where we actually filmed it to make sure how our processes were working, and it was the one comment. We used a real stroke survivor, so one of our previous patients came back and pretended to be having another stroke for us, and we had ambulance, we had everyone come through, and the one thing he said to us was no one told him he'd be okay. That was sort of the one step of the process that we did miss, so it was one thing that we have learned, and we try and make more of an effort. And it's interesting watching new staff come through. The one thing that they forget to do all the time is introduce themselves. So I think it's something that we do need to work on a lot more in hospitals, because we tend to be so obsessed with getting things done that we forget the basics. So as Michelle said, so I'm a nurse practitioner, so it's a new role within nursing. Well, it's not a new role, but it's something that's not very well picked up in New South Wales. We're a lot further behind than the rest of the country, but it's sort of like an advanced practice role within nursing, and it gives me sort of an extra endorsement on top of my registration that allows me to effectively on my own diagnose, prescribe, and do whatever treatment I need to do for a patient. So I don't need to work with medical staff necessarily, I can work independently, but the idea of an NP is to work within a multidisciplinary team, so then we provide better care for everyone. And I think as a nurse, I develop a lot different relationship to what other members of the team do, so it allows me to sort of more thoroughly work within that relationship and then add different things to it in terms of clinics and things. So within my role at RPA, it's changed a fair bit over the last 10 years or so, but basically I am the team leader for our stroke department. So I run all of the stroke calls, so we get new doctors who come through every couple of months. So it's my job to train them in how to do stroke calls and how to do the assessment and what history to gather and do that. And so I sort of take a lead in that. I make a lot of the decisions, so I'm the one who decides what treatments to do, who gets admitted, who doesn't get admitted, and what we can do from there, and what assessments people need and what scans they go on to. I do a lot of the talking with families, so finding out more of a story, because often the changes several times with the Chinese whispers of people coming into hospital. So I do a lot of talking to families, finding out what's going on, what the history is, exactly what care they would like for their family as well. And then doing a lot of consenting of patients for treatments when needed, and then coordinating all of the other teams. So as I said, stroke doesn't involve just one department, it's multiple departments throughout it. So I tend to be the one that talks to most everyone and gets everything up and running. So the whole point to hyperacute stroke care is time is brain. So everything we need to do needs to be done as quick as we possibly can. So I jokingly have a bit of a, well, it's not really a joke, I'm a bit meaner than that. I tend to have a KPI set in our department that we have 3 minutes to get out of the emergency department. So by the time you get into ED, there's 3 minutes before we need to be on our way to CT. So that means we have to have had a story, bloods have to be taken, cannula has to be in, we have to have done an assessment, and a scan has to be ordered before we're out the door. So there's not a lot of time for other things to happen, so it needs to be a very streamlined way of asking things. So I do have a lot of very strict rules around how things are done within our department, but we know that in terms of door to needle times, which is one of our set KPIs, it's 20 minutes. So from the time you hit hospital to the time we give you that drug, it should be 20 minutes. I'll give you a caveat that not one hospital in Australia manages that 20 minutes. It's very different services overseas that have very, very different setups that are able to achieve that. But in Australia, our aim is under 60 minutes you should be treated, with a gold standard under 45 minutes. I will tell you that my hospital has that. If they don't, they have please explain report cards sent out from me. So then we look at the outpatient care. So there's lots of different clinics and things available. So Liz O'Brien, who's another one who would present regularly, she is an MP who runs a TIA clinic. So anyone who has a TIA doesn't necessarily get admitted to hospitals anymore. So she brings them into her rapid access clinic, and they do all the investigations, all the assessments and the education in the one day. There is acute stroke clinics where once you've been in hospital, you've had your stroke, you get your follow-up at whatever time frame it might be afterwards. People come into those clinics, so I run those clinics along with our doctors, and there are other stroke CNCs who are involved in those. Secondary prevention clinics at RPA. So for us, that looks like after you've had your acute phase of the hospital stay, we bring you back in long-term monitoring of your blood pressures, your cholesterols, things like that. So we can keep a longer-term surveillance on patients to reduce the risk of stroke. For me, the stroke reperfusion clinic, anyone who has IV thrombolysis or clot retrieval at RPA, I follow them up 90 days later just to make sure our service is having the same outcomes as what the evidence shows and to make sure that we're doing the correct thing. And then for RPA, we're very lucky in terms of nursing, but our outpatient clinics is only staffed by nurses. We don't have any technicians. So all of the investigations, testings and things that you have done at RPA is done by nursing staff. So that way we can do the testing, but they can also assess patients and make sure people are going the same. And they've got that education in the background. Unlike a lot of the technicians who are trained to do the procedures, they're not trained to look at everything else as well. So that way it's a quick alert to the medical staff if there is something going on. Education is another thing, as I've spoken about. So when we look at what we're doing in terms of stroke education, we're looking at what an actual stroke is. It's amazing the amount of people who don't know what a stroke is, and if they can't move their arm, they think there's something wrong with their arm, rather than the links between a brain and an arm. So we need to do a lot of explaining around what a stroke is, what a difference between a TIA is, and I guess a lot of people have no reason to know what a stroke is until they're faced with that. So it's a lot of teaching, and I think it's a lot of trying to explain that it is actually a very serious condition. Whether you've come out of it with no deficits or whether you have, it still is serious, and it's a warning sign, and it's something to look at moving forward. Stroke risk factors. So I know a lot of people might come into hospital, they've got no stroke risk factors. There might not be a cause, but it is something you then need to look at moving forward, what your risk factors are and what you need to look for and how you can manage those. Lifestyle and behavioural changes. Every single person needs to know what sort of lifestyle changes they need to make, and that's a large part of what our education is. A stroke workup, I think, is something that's done haphazardly at every single hospital. Everyone does it slightly differently. So I know at RPA we don't necessarily provide an MRI for everyone. We don't have enough access by any means, but it's also not necessarily something that has to be done for every single patient. So it's knowing what part of a stroke workup you need, explaining what it means. I think anyone who's ever had an echo knows it's probably not the most pleasant procedure whatsoever. It hurt a lot more than what I expected when I had one. But I think explaining those things so people aren't shocked when they turn up for just an ultrasound and they're shoving a probe up under your rib cage. So I think it's explaining what it all is, what it actually means, and what that's going to mean for you. Because I think a large part of the stroke workup, a lot of it is purely academics. I think a lot of doctors are doing an MRI scan purely for their benefit, just so they can see anatomically exactly where something is. It doesn't necessarily change anything for you as a stroke survivor in that bed. And I think we tend to forget that because everyone sort of hangs on what the MRI results are, not realising it's going to have very little impact on you. So I think it's a good part of what we do to try and prevent that. Secondary prevention. The media has a lot to explain when it talks about medications for cholesterols and things, with the amount of people who stop taking aspirin, stop taking cholesterols because their cholesterol's normal, my blood pressure's normal, I can stop taking those medications. It's not how it works in terms of secondary prevention. So a lot of our job is to say, unfortunately, you're probably going to be on these medications for life now. You're not going to change these, and the drugs don't necessarily work just by reducing a number. They have other implications from pharmacology that actually then prevent longer term damage. The role of a stroke team. You would have all, during your times in hospital, seen there is 1,000 different people who are part of it, not necessarily knowing what all the jobs are, what an OT does, what a physio does, what a speechy does. So explaining what everyone's role is, so you're aware when they turn up, who's going to do what for you. As I said, the discharge planning. Our length of stay on average at RPA is under 4 days, so it's not a lot of time to get information, to learn what's going on, and to then know what's going to happen to you when you go home. So it's a lot of telling you where your follow-up's going to be, providing you with contact details. So if you do have worries when you go home and you're not sure what to do, making sure that there's someone that they can call and they know where to get those answers from. life after the hospital. I think for a lot of patients, especially when they're getting younger and younger, think they can go back to work the next day, making sure that people realise that this is not necessarily something that's over and done with tomorrow. You guys would know this better than what I would, but making sure they're aware of the long-term problems that can be around fatigue, returning to work, all those sorts of issues. And if we provide that education and then we provide them Michelle's details so they can call her later, then at least they've got those contacts. They know who to go to. They know where to get that support. I've got a lot of my young strokes that I've kept in touch, and they meet together for coffees. They do things like that. So at least they know who they can go to and who they can have that support from. Because as much as I can educate people about it, I've not been in that position. So I actually don't know for myself. So it's easier to hear from you guys, not from me. And then what's next? I think that's probably the question that no one can really answer, but I think it causes a lot of anxiety for a lot of patients when they're going home. So just having someone they can sit down and talk to that's not necessarily rushed off their feet like the 4 nurses at the bedside, at least we have that additional person that we can talk to, we can provide that support for everyone. And then research. So Australia, we're very lucky. We've got Professor Sandy Middleton, who was actually a nurse who's done some extraordinary research in stroke, and she was one of the few nurses who's actually managed to find that nursing care had more benefit on stroke survivors than anything else did, in terms of doing swallow screens early, maintaining your blood sugar levels under a certain amount, and maintaining your temperatures. That actually had a 30% improvement in outcomes, and it was all just down to basic nursing care. So that was sort of our leader for nursing research, and it's a lot of things that are trying to happen more and more in terms of nurse-led trials rather than all being drug-related or medical. We do a lot of running clinical trials within hospitals. So a lot of the trials that are implemented throughout the world are coordinated by nurses within the hospital. We're the ones who identify what patients are appropriate to go in there. We recruit you into the trials, and we tend to do your follow-ups afterwards. And then, yeah, as I said, so the study coordination. So the nurses, the trials coordinators, are the ones who tell us what the protocols look like when we need to do certain blood tests, when we need to do certain appointments, when we need to do different follow-ups. And I think nursing research is an area that's very much expanding and moving forward from there. You guys would all know the FAST sign, and I guess it's one thing that's probably nowhere near as well advertised as what it probably should be. And I make my mum, who's in the audience, often take FAST cards out to her friends so everyone knows what a stroke actually looks like, because it's still a large proportion of people who don't make it to hospital in time to be treated. So a large part of what we do is to try and educate patients, and just because they've come in and had a stroke doesn't automatically know what they mean, don't know what they mean FAST is. So it's explaining it to them, and if it ever happens again, call 222, don't drive yourself to hospital. Call 222, sorry, that's a hospital emergency. Call 000 to try and get yourself help. If you're in a hospital, call 222. So that would be the one thing that then tells you when you should be coming to hospital. We still know, especially the young stroke population, they don't necessarily get as treated as quickly and diagnosed as quickly as what they should, but we need to try and get this one out there before we can move on to the rest. So that FAST positive is what activates an ambulance. So if you were to call an ambulance and say you think someone's having a stroke, they would then take you to a stroke appropriate hospital. So if you don't say that, they might take you to your local hospital, which doesn't necessarily treat stroke. So if you were to ring from here and said you're having a stroke, they would potentially bypass you to Gosford Hospital rather than Wyong Hospital that has a stroke unit as a thrombolytic capable centre, and they would assess you faster and have those processes in place. So if the ambulance turn up and decide that you are FAST positive and you're within 90-minute driving time to a hospital and you're this area 4.5 hours under a stroke, under FAST positive onset time, they will take you directly to Gosford Hospital to be treated. They will then call us at the hospital, so we know that you're coming in, and so we're waiting in the emergency department for when you arrive. So often when you wheeled into the resus bay, you've got the stroke team standing there along with the emergency team standing there, waiting for that, for me, 3-minute countdown to get you out of the emergency hospital. And it is a bat phone. It's what it is in every single hospital. And that's what they call through. It's got a different ring, so we all know to look out for it. So as I said, it's those triage nurses who are the ones that get you into hospital. If you have a stroke call, we do tend to bypass triage and they come straight into resus, and triage do it at the same time we do, just to save time. But otherwise, if you were to drive yourself up to a hospital, it would go via that process, and then that does tend to slow things down. So if we've got pre-notification, it does make things faster. They are working, and Central Coast is on phase 2 of taking that time frame out to 24 hours rather than 4.5 hours, but it's just gone live in Metro Sydney to the 24 hours, and it will come up to Central Coast hopefully very soon. So the 24 hours I will get to shortly, but that's because endovascular clot retrieval is eligible out to 24 hours as opposed to thrombolysis, which I think we go through those times in a minute as well. So as I said, so the stroke team, our main job is to coordinate to make sure everyone's aware as to what needs to happen, to do that quick assessment and to try and get that decision making done as soon as we possibly can. So the sorts of things that we go through, actually I think I've got that later. So this is a picture of one of our stroke calls. So you can see there's about 15 people in an extraordinarily small space of time. This was pre-COVID, before anyone makes a comment. So post-COVID, most of those people aren't allowed to be in there. But ambulance love to be in the room, so they come through to check out scans. We've often got out for us, we have an interventional team if I've called them to come through. We've got the ED team, we've got a neurology team. There's a cast of about 5,000 people in there. And as most of you know, the more people you've got in a room, the less likely anyone is to do any work. So it tends to be me that's making people, giving jobs out, making sure that the actual jobs that should be happened does happen. So I think a large part of my job is telling people what to do and pushing people away. At that point, I'd be kicking most of them out of a room if we've actually got decisions and things to make, because too many cooks spoil the broth, as you would all know, and it doesn't work. So we do tend to try and make sure that it's the appropriate people who are in the room when it should be in the room. But a lot of this does help in terms of the ambulance in my area are amazing. They know, they've listened to me do enough conversations on the phone to try and get histories that they ask all the right questions that I want to know. I've had ambulance officers who come in for a person who lives alone to try and work out onset times for me. They've bought 7-Eleven receipts in saying they bought milk an hour ago, Kylie, so we know they were okay then. They'll bring in phones so we can go through phones. They'll do all of that. They'll tell me what they were wearing that was different to what they were wearing yesterday, so we can try and start our identification of detective work to work out onset time. So that's a lot of why we have the ambulance come with us, because we can then educate them. They can tell us more information. And they also get to see what the end results are as well. They get to see how well FAST works in terms of who's having a stroke, who's not having a stroke, and it sort of tends to make processes a lot better. We tend to have a lot more probably pre-notification than a lot of other hospitals do, and I think it's because we have these good relationships with them, and we do spend a lot of time talking to them and working through them what we need to happen. So our idea of a quick neuro exam is what's called the National Institute of Health Stroke Severity Score, and it's 11 different things that we're looking at, but we're basically looking to see what power you've got in your arms, what power you've got in your legs. We're looking at your visual problems. Can you see everything, or have you lost some vision in one side? Can you smile? Have you got a facial droop? We're looking at, can your eyes move all the way across to both sides? Can you talk to us? Are the words you're using the appropriate words, and are you speaking clearly, or are you slurring your words? Have you got like a neglect? Do you know what's happening on both sides of the world, or have you lost that ability? And we're looking at sensation. So is the sensation the same on both sides of your body? And we're looking to see whether you're clumsy. So are you ataxic? So can you touch things? Can you do things appropriately? So that is what should take us less than sort of 90 seconds thereabout. So it's very quick, it's very crude, but it does help us to then identify what area of the brain you're probably having that stroke and how severe that stroke is to what our treatments are potentially going to be. So we do that really quick assessment that then helps me to determine where we're going to go from there.
Can I ask a quick question?
Yeah.
If you are asking the people, like someone that's come in,
Yeah.
are you talking that fast to the person on the end?
So you'd be surprised at how well we can actually do a stroke score to get people to understand
Because
in a short space of time.
For example, if you are asking me all those questions now,
Yes.
Yeah, so it's not all in one. So we literally go down, and depending on your deficits to how I would organise it. So given I've done enough of them, I can then base that around what I can see for you. So if I know that speech is a problem, we then go about doing assessment a different way. So if you haven't answered my first question because you're not able to understand and you're not obeying commands, I then completely redo how we do it. It's not necessarily asking questions, but we stand there and we mimic things, and we're getting them to do what we move arms and legs. So we can actually do it in different ways that's not as bad as what it sounds. So it's very quick, but it works. Yeah. Yeah, so the questions we're asking are literally what's your age and what's your month. They're the only main questions that we ask for you to answer. And then a lot of mine, depending on how long you do it, I will then talk to you about your family, your medical history, and then I can work out how your speech is going through it. So we sort of combine things to make it a lot quicker and a lot easier for you to navigate. Because we've got stroke, don't necessarily speak at all. We've also, in my area, there's a lot of non-English speaking people. So we do learn to do it mimicking and doing it always. So we can get the answers out in that short space of time. You'd be surprised. Because we even do it around when they're putting cannulas in, they're taking bloods. They've got someone else who's doing rat tests now. So all of that is sort of being done simultaneously. So, and I think that's where a lot of the reassurance and things has to come into it, because it is extraordinarily quick. You come in on an ambulance stretcher, you've got about 6 people who are all standing there. It's got to be terrifying because, yeah, we're attacking you from all sides. So it tends to be then on the way through to scan, we're talking through more of what's going to happen, because then by the time you get to scan, they're put on the radiology bed and they're on their own for 10 minutes. And it must be absolutely terrifying to have had 10 people all of a sudden attacking you from all sides to then being on your own, not knowing what's going on.
So with this COVID, has that also made it longer?
So COVID most certainly has slowed processes down.
Someone is having a stroke?
Well, so it has theoretically slowed processes down, but everyone gets treated like they've got COVID. So we're all wearing full PPE for every patient that comes through. Everyone gets a quick swab, and then we all go on a COVID pathway. So at RPA, we've definitely split our processes into 2, and we've got hot and cold pathways. Every stroke automatically goes on a hot pathway. So that way we're not slowing down our process, and we're not infecting other people as well. For someone who might have COVID, might not have COVID. Yeah. And then we tend to get a quick history there as well. So that's often the handover from the ambulance staff. And then once we've got enough of assessment to determine if someone's eligible for hyperacute stroke therapy, either myself or one of the medical staff will be on the phone to the family to try and get some more information whilst we're going around to scan. And then the ED staff will often be getting a bed, because gold standard is you don't get offloaded off an ambulance stretcher, you stay on the ambulance stretcher the entire time. So we go around to a radiology on the ambulance stretcher. Yes, Brenda? Michelle's going to yell at me.
Sorry, can I ask, you know how many ambulance seeing patients, do they do that on the day? Are they still doing it on the day?
So yes, officially. So this assessment tool that I just quickly spoke through has a shortened version that ambulance officers do, which will help us facilitate in terms of whether people are having a large vessel occlusion. There is a protocol in place that ambulance do it, but it's done fabulously in the Hunter. It's not done fabulously outside of the Hunter. Yeah, so I see it occasionally, and it tends to be the junior ambos that do it. Whereas the Hunter use it all the time, so they do it a lot more frequently. Yeah. All good. And so then the ED team, so generally if it's pre-notification before they get there, they've piled up a bed that's got our stroke box, it's got all our drugs that we need, it's got a monitor, it's got all airway equipment, and then that bed comes around with us to scan, and then when the patient's off the stretcher, they get onto that ambulance bed, off the ambulance bed onto a hospital bed. Then once we've deemed you eligible for a stroke call, so a lot of patients who come through what might be fast positive, by the time they get into hospital, it's obviously a Bell's palsy or something that's not stroke. So we're not going to do the whole stroke series workup on them. So we would step those down. But if you make it to what we think potentially you are having a stroke, we will always err on the side of caution. And if we're not sure, we will always scan rather than worry about missing someone. We take everyone around for CT. everyone gets what we call the trifecta or advanced imaging. So everyone gets a non-contrast CT, a CT angio and a CT perfusion, which will help us determine whether someone's eligible for endovascular clot retrieval and whether they're eligible for other types of treatment. So the non-contrast CT will show us whether you've had a bleed or whether you've got an established stroke on scan. The CT angio will show us if you've got a blockage in a blood vessel, and the perfusion scan will show us if there's any area that's got decreased blood supply. And depending on your hospitals, there tends to be a radiology nurse at that point who assesses your allergies, whether you're allergic to iodine and contrast before having the scan, and then the cannula that you get put in. You might often get a second cannula put in when you come to hospital because we need a really large bore cannula to be able to push the contrast through at a really high rate, and so the cannula doesn't hurt you when we actually give the drugs. So once we're in the CT, so the CT probably takes 10 minutes and it's done and dusted. So ideally we're at about the 15-minute mark of you being in hospital at this point. We are then reviewing the imaging. So we tend to have a look. We're very spoiled at RPA. We have a radiology team who come to all of our stroke calls, so they help review scans with us. We're looking at the blood results. So if anyone is anticoagulated, so if you're on warfarin, we have sent life-threatening blood, so they should be back by then, so we know what the blood results are. And if someone has some medical conditions that might impact their platelets, they tend to be the only bloods that we wait for, and we wouldn't often delay any treatment for anything else. We would tend to ignore all other blood results. We would be working out what your medical history is. So I think one of the hard parts is that everything has to be done so quickly. So often when we're ringing families, especially in COVID when you can't come into the hospital, we're sort of firing about 10 very specific questions at you that we want very specific answers for, and we don't have enough time to go through every single issue. So what we tend to do is ring. I ask the set questions that I want. I want to know about any bleeding history. So have you had any, bleeding, coughing up blood or any problems like that in the past? So we can work out whether you've got any risks for thrombolysis. We're going to work out whether you've had any big surgeries, any big falls or traumas or anything in the last few weeks to work out whether you've got any risks around IV thrombolysis, and then any comorbidity. So if someone had a terminal illness, if they had a terminal illness and they were given 12 months to live, we would 100% treat them, no problems whatsoever. If they had a terminal illness and they were given a month to live, we would then talk to the family about what their options were. But our decision would be, even if you're dying, you still want to be able to die and talk to your family rather than die and be aphasic. So terminal illness doesn't necessarily rule you out of any therapy whatsoever, but other medical conditions might. And social history, we're looking at what your functional abilities were before you had a stroke. So if you had a stroke and before that you required a lot of care, you wouldn't be eligible for clot retrieval, but you'd still be eligible for thrombolysis. So we need to look at it on a case by case.
Do you have very much more of this to go on? I think I speak for a lot of victims now. I don't think we've taken half of it in.
Yeah.
All right, so would you like to stop?
I think we'll have
Do you want a break?
because, this is going on forever.
Yeah.
I would have to agree,
Alright.
one thing is great.
Yes.
But
How about we just stop and have some questions? So we can have some questions on what Kylie has done. Because basically, I guess it's information that's really important that you hear. So how about we have some questions on what Kylie's done thus far, and then we go on to the
Yeah.
okay. So, and what we will do is we're going to got a microphone here, and we'll go around with the microphone so everybody can hear the question.
Have we got questions now, or have we scared everyone? Yeah.
Okay.
Just a second. I've just got to check.
I need a microphone.
Do we need a microphone?
Yes.
Yep. Nothing at your mind. Thanks. Caroline.
Hello, my name is Caroline.
Hi, Caroline.
2 marks. 2 marks. Talking. 2 marks.
Okay.
Talking. 2 marks. Sorry.
No, that's okay. That's all right. Have you got a question?
No. sorry.
Like that question on there.
Yeah.
Yeah.
Is that right?
Too much.
Caroline had her stroke about 9 years ago.
Yeah.
She was in the ICU it was a pretty severe stroke for nearly a couple of weeks. When she came out of that, she went into the stroke unit within the hospital. On the first day, a nursing coordinator came in with a young doctor, sat down with me next to Caroline, who was, she'll probably describe it as she was still a bit out to it. And they told me she wouldn't walk, she wouldn't talk, and she'll be in a nursing home for the rest of her life. First day. Here she is here, she walks, she talks, and she's not in a nursing home. Now, what do you think about, what do you think about, because reflecting on it years later, I thought that's an appalling thing to do to someone like me and Caroline on the first day in the stroke recovery unit.
Yeah.
And it's all downhill from there, isn't it?
No, agreed, and I do think there needs to be a balance. I think you guys most certainly need to be hopeful, and you need to be able to think that things are going to improve.
Happy.
Yeah, and I think we need to play a balance, because I think we need to try and prepare people for what could potentially be the worst outcomes as well, because otherwise, my rule is always, I don't want people to be shocked if things don't go how you would want them to go. So it's walking that very fine line between making sure you're not surprised, but trying to still make sure that you've got hope. And we most certainly don't know all the answers. People have surprised me all the times in terms of how well they do. But on the flip side, people also surprise me that they don't necessarily improve as well. So I think, yeah, you're right. I don't think on the first day that should necessarily be coming out of anyone's mouth. We tend to wait a little bit of time for that. But yeah, it needs to be that balance between making sure everyone's got realistic expectations, but that everyone's still very hopeful.
And I guess while we think that may have improved, there are still some areas where it hasn't improved. And I guess that's part of our advocacy role in basically with ACI, is to make sure that we're always giving the other side of the story. And I think at the Rehab Network conference on Wednesday, we had 2 stroke survivors talking about their different experiences when they were in hospital. And that's only been in the last 12, 18 months. And again, the messages that they were giving to the rehab people that were in the room were really important ones. And it was around not writing people off, and also that whole issue of when somebody has more than one other issue, and I'm talking visual or physical, or even a little bit of dementia, it doesn't necessarily mean that their family is not going to take them home. So I guess what the area that the health professionals are trying to balance is that area of, this is going to be the reality for you when you go home, but ultimately the decision of where you go is up to the person. And I think that's a shift that still has to happen within the health system, and also with people who are going along to the health system and just buying whatever the doctor tells you as well. And, you know, I think one of the things that Kylie's talking about is that whole role of a nurse practitioner, which means that it's moving away a little bit from that medical model. You're getting a bit more human in there because, you know, in most situations, nurses have a little bit more, I guess, time to sit around the table. Some do. And we've got just before you go to you, we've got a question down the back.
Yeah, so there's a question online from Graham. He says that unfortunately hospitals still do not communicate with each other and other departments in other hospitals. So especially when a stroke emergency situation occurs, registers involved are not educated on these kind of situations. So what can be done in that case?
So I think that's a large part of my job. So we have a clot retrieval service that takes patients from across the state. And so a lot of what I do is then speaking to my equivalents at other hospitals and the medical teams at other hospitals to make sure if they're sending a patient down, we know what's coming down to us, but also when we send someone back, they know exactly what care has occurred when they're in our hospital. And I also still follow those patients up to make sure that I know that they've got their follow-up appointments, they've got a local neurologist. So I think we are trying to improve that, especially now with telestroke, where a lot more patients are being moved around. We're trying to improve those links across the state.
Can you also just talk a little bit about quality assurance and how that's done across the state as well?
Yep, so in terms of when we were looking at the data, so a lot of my job would be trying to collect data around what we're actually doing. So when I said we do, I can show you a picture actually. We've got So across New South Wales, we have a register that everyone enters data into. So this is sort of the main areas of the clinical guidelines that we all need to make sure that we're abiding by. And this is the World Stroke Organisation. They have set what our benchmark should be, so what our result should be in achieving that. And so most hospitals across New South Wales and across Australia submit data to this. So we actually then know how we're performing against the rest of the world in terms of whether we're meeting the set data points that we should be and you're getting the care that you should be receiving. So New South Wales, we do this every 3 months, and every hospital that gets either gold, platinum or diamond then gets awarded that status.
Sorry, just one more. How many of these practice, gold standard practice are being rolled out through New South Wales?
As in how many hospitals
Yeah.
get gold? About 5 or 6, I think, have been given gold status. 2, you guys would be very lucky to know Gosford got platinum last year, so they got a platinum award, so that's the second. And I'll try not to brag, but we are the only hospital in New South Wales that got diamond RPA this year. So we were just given a diamond award. No.
Are these slides available for perusal if we?
Of course, I'll give it to Michelle. Yep, no problems.
Cool.
You want to go?
So John Hunter haven't entered the data at the moment, so they're not one of the hospitals that are entering data. But John Hunter provide good care, so it's not compulsory to enter data. So it depends on your hospital to whether you enter the data or you don't enter the data.
And it doesn't mean you're not a good hospital
Yeah.
if you don't enter the data, so.
It's just depending on your hospital's priority. Yeah.
It's just that I guess there's different ways that the hospitals choose to, determine whether or not they're providing a good service, and there are, and
And John Hunter provide a good service, like they do provide a lot of other information.
But it's just that they do their quality assurance differently. I don't know why.
So the problem is for a clinician to enter the data can take a lot of time. So without going into all the issues, we don't all have the same computer systems. So there's no way for it to directly pull from our computer system. So we're working on that to then be able to make it automatic that the data goes across, and then all hospitals will. But at the moment, so this is something that started rolling out through ACI last year. So we're rolling it out. So I was the first ECR centre to trial it, and John Hunter's an ECR service. So we've trialled the data, so we know it works. So it will start rolling out.
Okay, just a few little questions. Do they still tell people that have had a stroke that what you are now, you have to work hard in the first year and then that's it?
I've never said that, so no, I don't think they do.
Specialists do, the doctors
Yeah.
do. Another one is, do they explain to the person that had the stroke and the family what aphasia is? Will that make them better? Because if they don't start telling people about that, people think they're never going to talk again. They're not going to read, they're not going to write, they're not going to, these is one of the things, the first things they should tell to people is what it is about. Don't tell them they're a vegetable and this is what you're going to be like for the rest of your life and what you are in the first year, this is it. That's wrong.
Yeah.
You have to, I want everyone to know what it is.
No, agreed. So I think, as Michelle pointed out, I think the consumer voice is something that we need to use a lot more. So I know I've brought some of our stroke survivors back to talk to the staff, because I think unless we hear about it from what you guys are experiencing, we don't necessarily know what to change. As I said, we do rounds and we think we've explained things. It doesn't necessarily mean that's what's been understood and that it's explained properly either. So it is something that we're trying hard. And I guess I do get a lot out of these, coming listening to what people's experience are and how things were explained, because I will say I've never told someone that in 12 months' time that's what your peak is going to be. I think I had a completely different conversation this morning, but I think everyone's experience is very different. I can't talk on how everyone speaks. We all sort of approach things differently, but it's most certainly part of our teaching now. And a lot of we've organised some mentor programs and a lot of things to try and get a lot of us together and a lot more sort of involvement across the state, so everyone's doing things in the same way. And I guess unless we hear about it, we can't then change it.
I'd also like to make a comment on that as well, because I get a lot of calls like this. But you've also got to remember that people who have had a stroke are in a crisis at that point in time, and their family are in a crisis, and they're being bombarded, as Kylie has indicated, with an awful lot of information. And sometimes you can retain some of that information, but you can't retain all of it. So I guess the fact of the matter is we have to hear, even I do, many times now, don't I, Rachel, have to hear information several times, and particularly after a stroke, before we take it in. So it's really quite important that not only do we have verbal information coming at us, but written information coming at us. And I know, we're getting very high tech and people assume we can all go on computers, but sometimes having that piece of paper in front of us where we can read something again and again and just take it in. So the National Stroke Foundation has the My Stroke Journey booklet, which is given out, and the Stroke Association has the Practical Guide to Stroke Recovery and all of those sort of things. So you can get various information written in various ways, all of which make up a puzzle that is about whole person care. So Kylie and the health system provide one part of that puzzle, but there's a lot of other people out there who provide a bit more of that puzzle. And as Kylie indicated earlier, it's not only just coming, you're not getting information just from them or us, you're getting it from the media, and sometimes that's very conflicting. You're getting it from friends, and I was chatting to the lady and gentleman up the back who have a lovely gentleman who's an Amber who was a friend, and we gather information from a lot of places. But I guess what we have to always remember that no two strokes are the same, and your experience is not going to be the same as somebody else's. But it's great to compare and then say, well, they've done well in this area and I struggled. This is the technique they used. And I guess that's just part of the process that we're doing as part of the whole education of just one stroke journey. But there's various stroke journeys out there, and we learn from each and every one of them. And I think that's one of the real joys of New South Wales Health, is that they're so much more open to learn about your stroke journey now than they were 25 years ago when it was just beginning. And not only are they open to learning about it, but they utilise what they're hearing to make their services better. They really do. Yeah. So we have another question.
Hi. You said that you only do one clot retrieval. Is that right?
You can only do one.
Yeah.
No, we've done multiple on multiple
Okay.
people. Yeah, so no. Anytime if you've had a stroke that's appropriate for a clot retrieval, you'll get one. Yeah. Yes. Yeah. I did 2 on a patient last week.
Okay.
Yeah. Not me personally, but yeah, we did. Yeah, same as you can be thrombolised on multiple occasions.
Oh, there you go.
Yeah.
See, you learn something new every day you didn't know. Kim has a question.
Yeah.
Hi. The clot retrieval, is that happening in all hospitals? Because when my daughter had her stroke, she was unable to have the clot retrieval because her stroke happened on Friday evening, and the nearest hospital that would do that was closed. So has that improved since 2016? This is what I'm trying to say, because that was pretty sad to think that in a large regional centre they say, oh, sorry, the hospital's closed, we can't do that now.
So I'm not sure if my answer is going to help you because no
It's
regional
not going to
centres
make
do.
any difference, but I would like to know that there is an effort being made to make it better with the telehealth and that sort of thing is hopefully
So
going to be
clot
improved.
retrieval, the evidence was only started in 2015, so that was when the first evidence was out there.
Well, she was
So-
told that they couldn't do it because she couldn't be moved on to to a Sydney hospital because it was too late.
So that's most certainly changed. So in terms of clot retrieval, so we've been doing clot retrievals for about 20 years now, so it's not necessarily a new thing, but as a 24-hour service, so my hospital is open 24/7, and we've brought people in from, so we cover Canberra, South Coast, we cover all of West. Yep, so we do cover that. So John Hunter have a 24-hour stroke service, as do us. Prince of Wales and Liverpool have a combined one, and North Shore Westmead have a service.
So does the particular hospitals only go to particular hospitals?
So we all have our set referral patterns,
Oh, okay.
There is a lot of hospitals that don't necessarily take every single person, but there is always a centre that's open 24 hours. So, for example, RPA, we don't ever say no. So if someone needs it, we transfer you in no matter where you are. The issue is how you get to us. That might be delayed a bit, but we don't ever say no. Telestroke has now gone live in 23 centres across New South Wales. So they assess and they refer to the appropriate centre. And if they refer to John Hunter already had someone on the table, they would then refer to us and we would then cover.
So can all of the regional hospitals, they have people who are qualified that can come and do the clot
No,
retrieval?
so they would be sent down to us. So the problem is you have to do so many a year to be credentialed.
Yeah.
So it's all done in the major centres at the moment.
Yeah.
Yeah.
Okay. Oh, well, these things are,
And you need the correct imaging as well.
Yeah.
To be able to do it appropriately. Any other questions?
My strokes too. What?
You had 2 strokes, Tamworth. And are you asking, is Tamworth able to do these things now?
So Tamworth has telestroke. So telestroke works, so it's worked out of one hospital, and telestroke go into Tamworth. So they have cameras that are set up and they will assess you the same as what we would, someone who came into RPA. They assess you via a camera and then they would treat you so they would give you thrombolysis at Tamworth. And if you were eligible for clot retrieval, they would send you to John Hunter or somewhere else.
And John Hunter's 24-hour clot
John Hunter is a 24-hour clot retrieval service.
So wherever you are,
You will
go
get treatment, yeah.
To one or other of them. It's the 5 centres, would you call it?
6, yeah. 6 with 4 that do 24 hours. So even if you were in Lightning Ridge that they don't have imaging, retrieval would still think if you're having a stroke, they would just automatically send you down to us, which they routinely do, and they say, we think this person's having a stroke, we'll bypass all other hospitals and send you directly there to us. And so that does happen on a regular basis now. I know things are improving a lot more. They weren't so great. 2016, when you had those issues, there was a lot of fighting to try and get services set up. And so now they are pretty set up and they're pretty routine and things do work reasonably well.
And things are changing very quickly. That's the other thing too. It's not as if, as Kylie said earlier, the National Stroke Guidelines are now what they call a living guideline, which means they're changing all the time. And so part of the clinical nurse consultant's role is to keep on top of what those guidelines are and to make sure those changes are implemented in their hospital. So it's an ever-changing feast, and hopefully what comes next is better than what each and every one of you in this room experienced, I guess. Yeah.
And I'm the person with the mic at the moment.
I'll let you ask a question.
No, it's kind of more information and not a question. My stroke was 21 years ago, and so I sort of know how much has changed in those 21 years. But I'm also really very lucky to be involved with people like Kylie and Michelle with the Stroke Network, Agency for Clinical Innovation Stroke Network. And all that ambulance bypass stuff is kind of literally happening at the moment, so that that country regional areas will get to the right place and ambulances will get to the right place. But I don't know how many people in this room know, but Michelle has a voice on the Stroke Network at an executive level, but also there's a consumer voice at an executive level at ACI. And so, That's me. And so I love hearing from people about what their thoughts are, because as a consumer, I'm the person who asks the hard questions, as Kylie and Michelle can tell you. I do ask the hard questions. So I suppose I'm just letting you know, please let me know what your hard questions are.
Most definitely, I think that's a lot of what we're trying to improve now in terms of health and get that consumer voice louder.
How long is the time that is given from the lysis?
So thrombolysis, on average, it's 4.5 hours, but there are some sites that will go out to 12 hours, and then clot retrieval's out to 24 hours.
We have a question online that asks, what is your favourite part about being a stroke nurse practitioner?
My favourite part, I must say I still love the stroke calls. I love the hyperacute stuff and the very quick moving, because I do think a large part of my job is being able to communicate, and that's probably my favourite part. I do love it. I know you guys probably don't, but I love a good stroke call.
And that's because you can order people around. So I just think
exactly right. But it's also satisfying. It's really good to be able to see someone who might have come in, they're aphasic, they can't move, and then the next day after you've treated them, they're able to get out of bed and walk and talk. I think that's amazing, and it's not something you often get to see. So I think that is really beneficial.
I remember that 30 years ago, that wouldn't have happened. 30 years ago, you would have just come into ED and you would have been sat there. You certainly wouldn't have been going through triage anytime soon. And then, if you were lucky, they put you in a corner and to see how you
It was the
respond.
part of nursing that was horrendous. It was those heavy patients in that medical ward that you could do nothing about. Whereas now we can see them walk out of hospital. It's so different to what it ever used to be. Yeah.
And so it was survive or die.
Yeah.
And now we've got this whole area in between, which is really good, because as each of you attest, there is quality of life after stroke, and really good quality of life after stroke. And it comes about because of the quality healthcare that we're able to access really quickly now, which is great.
Yeah.
Which is great. My kids know where I'm going. They know very well. Do we have any other questions at all?
Me.
I'll speak to first.
You.
Ladies first.
Over the hour.
Sorry.
The truth that I want to say, have hospitals come a long way since, I agree with Brenda, hospital have come a long way since, I had my stroke 22 years ago. So hospitals have come a long way, haven't they?
Yeah, they have, yeah.
Now,
But I think stroke care has come a long way.
but I agree with that lady, she's gone over there too. A doctor told me I'd never walk again. I was in a wheelchair for 2 years, and I said, I'm going to fight this. And I fought it. I went to an OT, and I finally got onto a walk out of a wheelchair.
Yeah.
I proved that doctor wrong.
And I think that's where a lot of you need to use that as motivation.
And yes, and I was completely paralysed down the left side, and I got moving again for OT. So
You've done
there you go,
extremely
I've done it
Yeah.
quite well. I said to the doctor, I'm going to fight this, and I did.
And I hope you told them.
Thank you, I did.
My theory, Victor, is that you need three things to recover well from a stroke. You need to get to really good medical care really, really quickly, and then you also need excellent and great support from your family and friends to get them. But the other thing you need is sheer bloody mind and determination, and often that comes out as belligerence. But that's okay, because it's about you getting your life right and back for you. And so those are the three things you need. So you obviously have that. Yeah.
Because I was completely paralysed down that side, and I got worse again.
Carolyn, you have another question?
And the hospital let me out there, hospital, 3 months later, I knew nothing.
Yeah, well, things have come a long way, but there's still a long way to go.
I am.
Kylie, another home, my home. What hurts? No. Rather Harris, my home. What hurts?
That hurts.
What Caroline's saying is, she did end up in a nursing home for about 7 months, and all the nurses were good except for one who was, the typical, I've got to do this quickly, I've got to do so many in a day. And, but the rest of the nurses in the nursing home were fantastic for the period that she needed to be there.
I think there's always going to be bad people, unfortunately.
The one thing I would say that Caroline's never actually gone back and done, probably for good reason, she wanted to go back to that stroke unit where that lady was working and walk in and give her the middle finger.
I don't think there's anything wrong with that, because I think some people need to be told.
Well, yes, but you can understand why I didn't take that.
Just sneak in there and do it anyway. Any other questions? Yeah. Keith has a question.
Thanks. Just to say that this file that's going to be produced that we can look at, and would you have somebody to add some notes from these questions and answers? Because some of them are really good.
It's being recorded, isn't it?
It's actually being recorded, Keith. So one of the things that Rachel does exceedingly well is she puts all these things together in a lovely little video, and we're putting those on USB so they can go out to your stroke club. So you can replay this. You can stop Kylie and listen again. You can push it forward, whatever. You can ignore whatever we say, but it's there for the stroke club to use in whichever way they want. So we just expect that it's going to go on, and it'll go on our website as well. So
I think it'd be totally great.
Terribly great, yeah. And can I just say to you, Carolyn, when I was in with my leg, I had a cannula in it. I don't believe any nurse who tells you any size cannula doesn't hurt, because it does. It does. And the other thing is, I had a nurse who took out the cannula, and if he ever came back in the room, I asked him to leave. And I told the nursing unit manager that if he came in again, I would have him up for assault. Okay, I was very direct. You do have some control over it, and unfortunately, when you haven't got a voice, and aphasia often can take that away from you, it makes it really hard, which is why we need our loved ones often to interpret for us, which is great. And I'd have certainly gone back and given them a figure on that. Do we have any other questions? No? Then what I'm going to do is I'm going to get Kylie to spend probably about 5 more minutes finishing up. And is there any particular area that we haven't covered that you're wanting Kylie to address? Yeah, what bits will there?
Oh, look, I can talk forever, Brenda, you know
I can hold a lot of things.
I can talk, I was just going through the general journey, I guess, and I was just talking about the role that nurses play at different steps. So I think a lot of it we have covered in the issues as well. Yeah.
Nobody else has another question?
Thank you so much.
Should we break for lunch?
Yeah.
I'd like to take this opportunity to thank Kylie for coming up today and for bringing her lovely Mingara. It's always great that people do give up their time to come and speak with us on these occasions, because it is a Saturday for Kylie. She doesn't work Saturdays most days, so that is good. But I guess one of the things that she has done today is she's given us a really good overview of how the process works. And none of us are immune from a stroke. And that may, for some of us, be our first stroke, but for others it may be our second, or even in Alan's case, possibly a third. So all of this information is vitally important to how we then view what's going to happen in our lives going forward. We're all getting older, and unfortunately stroke occurs at an older age, much more frequently than it does at a younger age. But I think one of the issues we're facing more and more is people are surviving stroke at a younger age. And they're surviving because we have now got excellent stroke care, right from that point of ambulance pickup right through to rehab. So, 35 years, 40 years ago, you would not have survived a stroke in a lot of cases, whereas now you are surviving and thriving. So it's really important that that message goes out there, and that's part of everybody in this room's advocacy role, to show that we can survive a stroke and we can survive it well, and we can go on to live a very healthy and happy life post-stroke. So on behalf of John Garbutt, our president, who I haven't acknowledged today, sorry John, so John's over there. On behalf of John and Judith Thornley, who's our Vice President and Secretary, I'd like to thank Kylie very, very much for coming along today and providing such excellent material for us. So we now move on to the second part of the day. Before we finish up, she who must be obeyed will be very annoyed with me if I don't advertise what's coming up for the association going forward. So we have a number of events coming up in the next couple of months. We have Stroke Awareness Week that is happening during September. So our Stroke Awareness Week will be from the 5th to the 11th of September. And we've got the Creating Connections Conference at Burwood on the 7th of September. And that will also be live streamed, so you've got no excuse for not sitting there in your own home and watching it. It'll be a great conference this year. We're talking about post-stroke fatigue. We've got people talking about cognition and memory recovery after stroke. And in the afternoon, we've got a fabulous session on the role of the social worker in stroke recovery, because we've covered everything in the last 12 months. However, what we haven't done is we haven't looked at the role of the social worker and how vital that is for people's ongoing journey when they get home. And Kylie has again come to the fore with that to basically provide us with a couple of excellent young social workers who are working at RPA and part of their community stroke team. And Royal Rehab will be providing a rehab social worker. And then the afternoon session will be looking at the endovascular clot retrieval journey of a stroke survivor, right from pickup to when they go back to home from rural New South Wales. And we've got the area of Bathurst Orange that's being highlighted with that. So that should be a really interesting day. And we've got the stroke choirs performing. Rachel's going to be going around to the stroke choirs and getting them to put together some choir material to finish off the day by showcasing how well our choirs are doing. So that will be excellent. So then we've also got the launch of Stroke Awareness Week, and that's going to be at Parliament House on the Monday evening. And all the executives of the stroke recovery clubs will be invited along to that, and you'll be most welcome to come. And then going forward, I guess we've got the Hunter Stroke Olympics, and all those of you who are represented here are invited to our Hunter Stroke Olympics. And Ross or Kath is going to correct me when I get this date wrong. So I'm hoping it's Tuesday, the 11th of October. Pretty close. Whatever that date is on that Tuesday, it's that day, okay? And that's at Raymond Terrace RSL Club. So you're all welcome to come along. We have to restrict numbers this year, so first in, best dressed, I have to say here, because it's growing in popularity and we've got a small room. So we're going to have to look at how we expand that as well going forward. But then in November, we've got the annual general meeting of the association, and that will be in Orange this year. So anybody who's willing and able to travel to Orange is more than welcome to come along and see what the association has been up to during our COVID times. And in addition to that, can I say that will also be live streamed, because Rachel's now learning a great new skill with that camera, and so we'll be live streaming that as well. So that will bring us then to the picnic, the combined class picnic, and that will be at, help me out, please.
Bobbin Head.
Thank you, Bobbin Head. Bobbin Head, and that will be, I think, on either the 11th or the 13th of November. 11th of November. Good God, I'm doing well with the numbers today. So that'll be on the 11th of November. So you're all welcome to come along to that as well. So that should be a good social day to finish our year. Okay, so I think that covers everything I need to say, but also don't forget that we do have our online groups and they're going along really well. So have a look at what we have on our website and see if you want to join in any of the wonderful groups that we have online, because they're growing. And again, a big thank you to Maitland Aphasia for opening up their group of a Friday to anybody with aphasia throughout New South Wales. That's made a real difference and connected our lovely friends from Tamworth more with the association and what we do.
We're on Zoom.
We're on Zoom. They're on Zoom, as are all of our
If you can't drive up to Maitland, we are on Zoom. every Friday, 10 a.m. to 12.
Friday.
Friday,
yeah,
sorry, 10 to 12. If you want the number, come and see us and we'll give you the number.
Oh, they go through this.
Or it goes through,
Yeah.
And there's just two more things I want to raise. With our stroke clubs, we're on our online stroke clubs, we're now doing basically a new stroke group, which means anybody who has any questions about their stroke or is a new stroke person to their stroke journey, we're having a discussion group once a month, which will cover some of those issues. So anybody who wants to come online and learn a little bit more about stroke or a little bit share their journey, that's available. And the other thing I want to point out is we're now doing governance training on Mondays, the fourth Monday of the month, where in the morning we're getting our stroke clubs to come online and tell us about the things that they're doing well within their stroke clubs. And in the afternoon, we're doing some of the governance training that the association is required to do by all the legislative bodies that we're governed by these days. So that's on the fourth Monday of every month, and you're more than welcome to come onto that as well. So I'm just asking before I finish, do we have any final questions? No? Well, again, a very big thank you to Kylie. I really appreciate the fact that she's given up so much time and come up to visit us today. So I'm now going to talk to you about how lunch is going to be organised, because this is where we get to the next part. We will have a bar that will be operating here on my left, and that will start up just as soon as I'm completed talking. For those of you who are staying for lunch, we will be having lunch served in this room. So it will be a matter of us organising the serviettes and the knives and forks and getting those all organised. Then round about 12:30, the lovely young ladies are going to bring the food out to here. If I don't know who you are, I'll be directing the girls as to where to take the food if I